Erin's one step ahead of me. Okay. Got it. So you should all see a little pop-up probably on your screen that said we're recording. We fully warned you now. Please consider yourself in public view. We do imagine that a lot of people will be watching this recording after as well. Okay, so I'm gonna go ahead and share my screen. I think I am. Doesn't everybody always say that when they, I'm gonna go ahead and share my screen. You think we've all had enough practice with Zoom now that we wouldn't have to announce it. Okay, so welcome everyone. We are here tonight to discuss an introduction to menopause and the pelvic floor. So I'm Katie Kelly, I'm a pelvic floor physiotherapist. I've been practicing for about 13 years now in the world of pelvic floor physiotherapy. And I really, the motivation for this topic has been the number of patients that I have had to work with. And I find that there's these various stages through life where women don't necessarily get as much education as they need, but more than we get at menopause. And so at puberty, you have a chat, right? You have this talk that will happen. And then during pregnancy and postpartum, maybe we're getting more of a chat now. I think like the birthing generation coming up right now have access to prenatal classes, they have access to postpartum care, there's social media, and they get a lot of information through online resources that maybe the baby boomers, Gen X, and the elder millennials didn't have access to. And so that population is kind of taken care of now. But then there's menopause. And I do find that there's really a lack of information on the topic of menopause. And so we've been seeing this, in our practice at Reconnect Health for a number of years, that you have women that are, going into menopause and don't understand the symptoms. We've got lots of women that have been suffering from symptoms associated with menopause for many years and don't know that there's physiotherapy to help, or don't know that there's medical help out there as well. And so we really wanted to start promoting through our clinic and on our social media campaigns that menopause is not this taboo subject that should just be swept under the rug. There's lots of things that you should be doing to promote a healthy menopause. There's lots of things that you can do to help the symptoms that you might be experiencing. And so that's really the motivation of this webinar tonight, is to start that discussion with people and maybe offer an introduction to some of the terms and some of the symptoms that we can see and how we can manage those. So I am the co-owner of Reconnect Health. Our flagship clinic is in Moncton, and Erin Matheson is my business partner. We've also just recently opened Reconnect Health Center in Fredericton. So we've got a satellite clinic there offering services as well. And we know that people have signed up from both regions. So welcome to everyone. I know that there's some people that have signed up from out of province as well. And there's quite a number of physiotherapists that are logging on too. So welcome everyone. Tonight's topics that I really want to talk about are, what is menopause? Because I think we should all have a good understanding of what it is. What is the pelvic floor? And then I have lots of these things kind of sprinkled throughout the presentation tonight of watch for this. So when you see two little eyeballs, these are things that you should be monitoring on yourself. So either symptoms or just like health related data that is useful for you to know. And then you will also see this symbol throughout the night as well. And it is, yes, in fact, marshmallows roasting over a flame, because these are for the tips that are promoting healthy aging. And so the tips are so hot that this seemed like a good icon to use. I don't know, we were limited in icons, but that's what you're going to be looking throughout the presentation tonight. So let's get started with, what is menopause exactly? Because there seems to be quite a bit of confusion about what menopause is. It's often described as a period in a woman's life when there's a significant decrease in estrogen levels, estrogen being one of our primary sex hormones. However, you can also see changes and fluctuations in other hormones as well, things like progesterone, DHEA, and honestly, there's kind of a number of other hormones that we'll see change during this time period. But it is one singular point in time that is exactly 12 months or 1 year after your last period. That's it. It just lasts for like this little blip of time. So anything before that time where you're experiencing symptoms is what we call premenopause, and anything after that kind of that the clock strikes 12 months after that is called postmenopause. But certainly we do see people use the terms menopause and postmenopause interchangeably. And so that's where some of that confusion can come from. The average age in North America of onset of menopause is 52 years. And we know that symptoms can last 2 to 10 years. So 10 years sounds like a very long time, but that's just the truth of the matter. And so for us as practitioners, we really do try to start having the talk, the menopause talk, with patients who are in their late 30s or early 40s, because if it takes a decade for people to have symptoms, they could be experiencing symptoms at that time. And also we know that some of the health-related changes that we see in bones and muscle can start as early as 35 or 40. And so we think that someone should have this information before they actually enter into menopause and start having these symptoms. So that's something to keep in mind as well. So the symptoms. So these are things, here's the little peepers, the little eyeballs are up in the corner. So these are things for you to start monitoring already. So things that are associated with menopause are, you know, the typical ones of an irregular menstrual cycle, things like hot flashes or hot flushes and night sweats, headache, fatigue, mood disorders. So we'll see changes, you know, depression, anxiety, that sort of thing. Difficulty sleeping, which certainly can be because of the hot flashes, but also independent of the hot flashes, you can have difficulties with sleeping, memory problems, weight gain, and genitourinary syndrome of menopause. So that's a bunch of pelvic floor issues, things that can happen with your bladder, vagina, rectum. We're going to talk about that in more detail. So we definitely want to have a good understanding of what is the vulva, the vagina, and the pelvic floor, because again, there's some confusion about the terminology of these different body parts. And as a practitioner, I'm always very appreciative when my patients know the difference, but it's very understandable why people would not know the difference. And so what we have here is a vulva. So a vulva is anything that you can see on the outside. So you have the labia majora on the outside, you have the labia minora, so majora and minora, and then I'm going to label these things for you. You've got the clitoris on top, and you can only see a very teeny tiny part of the clitoris externally. You then have skin that covers that little bit of clitoris over top, and we call that the clitoral hood. And the reason that I'm drawing this to your attention is that it actually becomes quite pertinent when we talk about health and monitoring our vulvar health as we age. So it's good to know where the external part of the clitoris is and the skin that covers it. We also have the urethra. So the urethra is the whole tube. I'm not sure if you guys can see my cursor. I'm going to assume that you can, unless Aaron sends me a message. So the urethra is like a tube, and it sits inside the labia minora. And you can see the tiny little opening is actually the opening to the urethra. And so sometimes I think there's some confusion about where the urethra is, but it sits right kind of at the top, right underneath the clitoris, inside the labia minora. And then you have the vagina that sits right underneath the urethra. So we've got urethra, vaginal opening is right there. And then the anus, the external anal sphincter is on the outside. So as far as the vagina is concerned, I turned the model that I just showed you in the previous slide to this side. And Aaron always likes to give the example, if the vulva is like your lips and mouth, then the vagina is your throat. So people will often interchange vagina for vulva, and that's where some of that terminology can be confused. But if you take my model and you turn it to the side, this tube that you see coming down, that's the vagina. And so if I have a patient on a table and I'm doing a vaginal exam on them, my finger does not go like up towards the belly button. It doesn't go up towards their throat. It actually aims back towards the back of the pelvis a little bit. And I find that a lot of women don't understand that angle, and rightfully so. We don't see a lot of vulvas. We don't see a lot of vaginas. It's hard to see our own. I can't demonstrate to my patients. And so learning about this body part can be very problematic, tricky, and then there's certainly a lot of taboo around it as well. So we have our first layer of kind of perineal pelvic floor muscle. This is not the true Kegel muscle, if you've heard of that term before. These are closer like to the external part of the pelvis, but we're looking from kind of a gynecological perspective. And what you can see in the yellow, that's a little bit of the clitoris that you can actually visualize externally. You have the urethral opening right here and the urethral tube around it. Then you have the vaginal opening. You can see the labia minora are there, and then they've resectioned everything else off so that you can see the muscles. You can see the muscle of the external anal sphincter there too. So this tends to be the area where there might have been tearing or damage that happened during childbirth. Sometimes when we do exams, we can see scars from where there's been an obstetrical injury. Those fade quite well though. You can also experience some dryness or irritation right at the vaginal opening, especially common with penetration or with sexual intercourse. And so we hear lots of complaint about, you know, people that are feeling like a dry irritational feeling there. So that's what we can see on the outside. We're gonna kind of sidetrack for a second for a little note on the clitoris, because I think this is very important. This is the clitoris, ladies, and if there's gentlemen here. But what you can see in that last picture is this little bit, like the little bit at the top at the end. So if I go back, that little yellow dot is what we're looking at right here. And so what a lot of people don't know, it's like the tip of the iceberg, right? There's so much more of that organ that sits deep into the pelvis. So I have it set up against the pelvis right here. Now it actually sits behind that first layer of muscle that I showed you, but just so that you can kind of eyeball where it is, it kind of runs along the pubic bones as they branch out to the side, and then it wraps around the vagina. And so it's much larger than people realize. And I think it's just something important for people to know, because certainly as we age and go into menopause, women will discuss symptoms of decreased libido, sometimes decreased sexual sensation, loss of orgasm. And I just think that having really good, proper sex, sex ed basically is important in being able to feel more confident in those discussions. If you do want to have a discussion with a health practitioner or with a partner, or if you just have interest in learning a little bit more about your body. But that is what the clitoris looks like and where it is located in the body, inside the pelvis. And then we have the deeper pelvic floor muscles. So I've taken a pelvis and I've turned it in perspective. So we're looking down into the pelvis, and almost like the patient's lying on their back. So this is the pubic bone, this is the spine. You can see the urethral opening is the first opening, the vaginal opening is the next, and then the anal rectal opening is further to the back. So this really demonstrates just a good visual to show you where the true Kegel muscle lies. And so I say Kegel muscle because the general public will often call it a Kegel muscle, named after Dr. Kegel. I don't think that he was the first person to discover this muscle. I assume that women have known about this muscle for millennia, and he just got credit for it. So you'll often hear pelvic floor physiotherapists call this the pelvic floor muscle. But it starts at the pubic bone in the front, and it slings between your legs all the way back to the tailbone. I specifically want to highlight this because I find the layperson often really perceives this muscle to be vaginally based. And if they're ever trying to squeeze or relax or activate that muscle, they're really thinking about squeezing around the vagina. When in fact, you want to activate or relax, you want to use the entirety of that muscle all the way back to the tailbone. And so it's important, I think, I'm a visual learner. And so for me, it's important to really have a good visual understanding of where this muscle lies. And that's why I love using these anatomy models to help people learn. But it goes from the front of your body all the way to your backside, to your tailbone in the back. This is a view from the side, and it's kind of putting the whole picture together. So we've got the pubic bone in the front, we've got the spine and the tailbone in the back. You can see the pelvic floor muscles starting at the pubic bone and running all the way to the tailbone in the back. And then you can see the bladder and the urethra as it comes through in the front. You've got the vagina and the uterus. If you've had a hysterectomy, then you probably have a little, like, so they would have removed the uterus. You probably have a little dome in there called the vaginal vault. And then you've got the anus and the rectum, which then turns into the intestines, the bowel, that sort of thing. And so that's what it looks like from front to back. And so the pelvic floor itself, spans across and supports those three organs, which is why you can see symptoms in all three of those organs if there are pelvic floor muscle issues. Okay, so the big question, is menopause a disorder? I kind of put this in here as a joke because I was checking the NAMS website to make sure that I was listing all the proper menopause symptoms. And so I put into Bing menopause symptoms NAMS, and this is what came up. If you can't see this, I'm going to read it to you. It says, it says menopause. If you or someone you know is exhibiting symptoms of menopause, seek medical attention immediately. So it made me laugh a little bit. Menopause is not a disorder. Certainly we recommend that you do speak to a practitioner if you are having symptoms that are problematic, but it is a normal part of life, and we don't want people to be afraid of it or to be disappointed by it. We want to kind of go into this life phase. Women can spend at least a third of their life, sometimes half of their life in menopause. And so we just think it's important to have good education on that subject. I also thought that maybe it's because I spelled menopause wrong in the search bar, but I went back and checked with the correct spelling and it still came up as this. So there you go. What I will tell you, hot tip, so here's a little roasty marshmallow. The North American Menopause Society, so NAMS, is actually an excellent resource for information on menopause. So it's very evidence-based, well-researched. And so it has information for both the layperson, general public, and practitioners. And so I strongly recommend that as a great starting point if you do have questions about symptoms that you're experiencing, or you do want a little bit more information. It's a great website. So what changes do we see with the pelvic floor in menopause? Due to the decreasing estrogen, we see a decrease in blood flow to the vulva and the vagina, and to be truthful, to the clitoris and the rectum as well. They all have estrogen receptors, and these changes can result in a decrease in the connective tissue support. So kind of like the scaffolding that helps hold the organs up and give support to the organs, that can decrease. We will also see, because of this, we'll also, like the loss of estrogen, we can also see a loss of elasticity in that area. We can see shape changes in the labia and the vagina. We can see changes in the vaginal microbiome, and the vaginal microbiome is like the environmental landscape of both good and bad bacteria in that area. I think the gut microbiome has become a term that's more readily acknowledged, and so vaginal microbiome is kind of similar, but of the vulva and vagina. And then certainly you can see vaginal dryness, so changes in vaginal moisture. And then, these pelvic floor symptoms that we're talking about can contribute and, be grouped together in something called genitourinary syndrome of menopause. Sounds very fancy. So we're going to jump into that. So symptoms of genitourinary syndrome of menopause are something that you should be monitoring for. See the little eyeballs? We want to pay attention to this. About 15% of women will develop one of these symptoms during their menopause transition, and then up to 80% of women will eventually experience one of these symptoms within their life. So that includes things like vaginal dryness or burning, pain with vaginal penetration, vaginal and vulvar itching or irritation, perianal dermatitis, a decreased ability to orgasm, increases in urinary tract infections, bladder infections, increased urinary incontinence, so more bladder leaks, or feeling like you have to go pee more often, or when you do get the feeling like you have to pee really, really bad, and then pelvic organ prolapse, which is a lowering of the organs into the vaginal canal. So we're going to talk about this in a little bit more detail. I don't want you to despair. Like I'm always hesitant in presenting some of this information because I don't want to scare people away and say like, oh, it's the same kind of concept I find that giving birth prep. Like I don't want to scare women when they're having babies, but I also want them to be really well informed. The same holds true for menopause. We can have things that are, problematic and symptomatic and bothersome, but I really feel like the more information, the more education someone has before they experience those symptoms. And so if they do happen, it's not as scary and not as unknown, a little bit more expected. I really do think that's valuable for women. And there are so many treatments, and I can tell you that, usually it's around January, February that there'll be these big medical announcements that happen. And I can tell you that we know of some that are upcoming. So like menopause in general has become such a better research topic. And I think that, to a certain extent, I think there are people that want to profit off of off of this. And so we do see more pharmaceutical options and treatments being offered to women. But at the same time, I'm happy that there are more options that are available. So there are certainly hormonal options. You might have heard of people taking estrogen, progesterone, that sort of thing. There's also non-hormonal prescriptions that are very helpful as well. There are things like vaginal moisturizers that don't have hormones in them, vaginal lubricants, which are different than moisturizers. Moisturizers are for like when you're moisturizing your face, right? It's a moisturizer. Lubrication is more for in the heat of the moment during intercourse. Topical treatments, there's different vulvar care methods, like there are ways that you should be managing your vulvar skin, and then there are things like pelvic floor physiotherapy, but I'm biased. There are also dietitians that can help, there are occupational therapists that can help, there are massage therapists and chiropractors who all have subspecialties in the pelvis and the pelvic floor, in women's health and aging. And so I think that really there's a whole medical team, a whole health pro team that you can be recruiting to help you out with these symptoms. So to start with, let's talk about urinary incontinence, because there are different types of urinary incontinence. And this is something that you want to be monitoring for, particularly because I find that in society, leaks have been normalized. It's kind of like, well, you're leaking. Well, you know, that's pretty normal at your age, right? And while it is common, it is like, it's normal. You're not abnormal to be leaking, but we don't want you to feel like there's nothing that can be done. And so that's where the difference lies. Is that you shouldn't just sit back and say, oh, well, I guess, okay, this is just the way it will be. There's lots that can be done that can really help with the different types of leaks. And so we're going to talk about some of the more common types of urinary leakage, because there are actually quite a few different ones, but one is general stress incontinence. And this would be the one where you would leak with a stressor or a pressure. So leaks that happen with coughing, sneezing, jumping, squatting, lifting, that sort of thing. It tends to be small to medium-sized leaks, but it can be larger leaks. You know, that can happen at any time throughout life, but we do see as the connective tissue gets a little bit weaker or less supportive in the pelvic floor, that this can certainly come on during menopause changes or leading up to it. Urinary urge incontinence, sometimes called overactive bladder. So that might be a term that you're familiar with, but this is the increased urge to pee. So you feel like you have to pee, but it's like a big urge to have to pee. Excuse me. You always get dry throat when you have to talk, right? Okay. Sorry about that. Or it can be an increased like going to pee. So you'll have to, like, because you get the urge all the time, sorry, because you get the urge all the time, you'll actually go to the bathroom more to help deal with it. Or you won't quite reach the toilet in time. So you might have some leaks as you're arriving to the toilet. Or I'll notice that sometimes it's like you stand up to go pee and your bladder has the same amount of urine in it. And as you reach the toilet, it feels like there's more urine in it. So we know that your bladder didn't change from the moment that you stood up to the moment that you got to the toilet. And so we know that that is a symptom of urinary urge. Or you can have symptoms of both of these. So you can be the lucky person that has like stress incontinence. So you leak when you cough and sneeze and laugh, but you also feel like you have to pee all the time. So really, this is something that we want you to be checking for on a regular basis, because there are lots of treatment options available to you, physiotherapy-wise, medical, like medications. There are some medications that can help with urge incontinence. And then we also have surgical options that are available, as well as kind of medical devices. And so the sooner that you seek treatment for these things, the easier those treatments are. We always want to see people before the problem gets to be too severe. So another thing that we really want you to be monitoring, and in fact, we often send our patients home with a bladder journal for them to physically write this down for us, but these are numbers that you should know. Maybe I'm a bit biased, but I've been counting my P's for about 12, 13 years now, which is kind of crazy, but it's something that's part of my profession. And so we want you to be peeing about 6 to 8 times in 24 hours. You should be able to hold 2 to 4 hours between urinations. Your pee should last about 10 to 16 seconds. Now, certainly that can vary between people and depends on urinary flow rate, but if you could count those. So I know that my pees are like 12-second pees. If I have too much caffeine, which make my bladder jumpy, then my pees will go down to 9-second pees. So that might sound a little bit weird that I know that information, but it's incredibly useful for me to be able to monitor what my bladder is doing. You should be able to control your urge on the way to the toilet. And your pee should look like a pale, pale yellow. So it should look not like apple juice, but not like identical to water either. It should have a little tinge of color, unless you're taking some vitamins that do dye your pee like a bright orange color. And so my recommendation is to try to keep track of that. You don't need to write it down to be obsessive, but if you're sitting down on the toilet, then you should have, like, 1 Mississippi, 2 Mississippi. And if you're noticing that you're peeing 10 or more times a day, that really is a point where you should be reaching out for some help on what's happening with your bladder. So hot tip is to try to track this for at least 3 days and see if you can get a general sense of what your bladder patterns look like. And then you can always take this to a pelvic floor physiotherapist. You can always take this to a physician, and it's a really nice starting off point when you already have this data collected. It builds a really nice clinical picture for us, or for those who are trying to get an assessment on what's happening to your bladder. Okay, pelvic organ prolapse. So I find that a lot of people, women, are scared about prolapse. Prolapse is when one of the organs in the pelvis, either the bladder, the uterus, if you don't have a uterus, then the vaginal vault that they would have created, or the rectum, lower into the vaginal canal. Sometimes you don't know you have it, and a practitioner might tell you because you've been experiencing some other symptoms, and it leads to a vaginal exam, and they find it on exam. Other women can actually feel it when they wipe, or they can see it. And we get a lot of panicked calls. I've had patients that have presented to the emergency room because they don't know what this bulge is that's coming out of their vagina. And I so feel for them, because it's so scary when it's happening to you, especially if you didn't have any idea that this could be something that happens. And so that's one of the reasons that we think that education is so important. So you don't have that panic moment. If this happens, you know what it is. It's not an emergency unless the vaginal tissues have been rubbing against your underwear or your clothes, and it's leading to irritation and bleeding. We can sometimes see infection, but that is very, very, very rare in our clinical practice anyways. But something to keep in mind. The symptoms that you might feel that are associated with this is almost this feeling of like heaviness and pressure in the vagina, like an ache between your legs. You can feel or see a bump down there. And I put the bubble gum picture because it kind of looks like this. So when we see like a bladder coming out at us, it really does look like this bubble that's kind of coming out. You can have an increased urge to urinate because the bladder is bouncing around in there a little bit more than before. And so it can make you feel like you have to pee. You can have difficulty with bowel movements. So if the rectum especially starts to come down into the vaginal canal, then it can make it, the tubes don't align up the way they should. So it can make it really hard to defecate. And some people will actually tell me that they need to put their fingers on the outside of their rectum, or they'll need to insert their fingers vaginally to have a proper, complete bowel movement. And so you're not weird or crazy if that's something that you feel like you have to do, but it is one of those symptoms that's associated with a prolapse. Not always, but sometimes. Sometimes you'll find that your tampon's being pushed out, or you can't wear tampons anymore. Difficulty with sex. And there is some research to suggest that this might be associated with some types of low back pain. Now, the research is kind of wishy-washy on there, but I did want to bring it up because we're seeing it more and more in the media, and we get asked about it a bit more. So sometimes that can be a symptom associated with it. So obviously something for you to be monitoring for, but if you do have these symptoms, don't panic, go get an exam done. But hopefully this leads less people to present in the emergency room with a prolapse. Painful intercourse, the fancy name is dyspareunia. It's a very pretty word for things that don't feel very comfortable at all. So painful intercourse is often described as like a burning sensation at the vaginal opening, ripping, tearing, sandpaper-like friction, especially when inserting something. So it might be penis-vagina intercourse. It might also be during a pap exam. It could be when trying to put a tampon in or taking a tampon out. It can be a blocked feeling, so feeling like you can't physically get something into the vagina, discomfort with intercourse, or no ability to tolerate intercourse at all. We hear of that all the time. Pain also following intercourse. So, it hurts afterwards, it's burning, itching. Sometimes you'll even have a little bit of bleeding. So like a vaginal, vulvar fissure that can happen, usually like a tinge of pink when you wipe after you go pee after sex is something that we'll hear described a lot. And occasionally deeper pain that feels like with deep penetration that's causing discomfort. So those are all common descriptors that we hear from women who do experience the different types of dyspareunia. Hot tip is lubricant. So I'm gonna kind of jump onto my soapbox here for a minute because lubricant in Canada annoys me. Also, I loved this picture. I thought it was a good picture. Thank you, stock images, for this topic. So after, like, leading up to menopause, if you're symptomatic and after menopause, we strongly recommend a silicone-based lubricant. And the reason for that is it's gentler on your skin and it's longer lasting compared to a water-based lubricant. There's very few ingredients in a silicone-based lubricant, and like the sciencey name, if you flip over the package to read, the sciencey name should be dimethicone or one of the icones. It will look like that ending will be on one of the words. They're not always advertised as being a silicone-based lubricant on the front, and so sometimes that's why you'd want to flip it over and double check the ingredients on the back. Now, compared to a water-based lubricant, because everyone seems to like water-based, it sounds natural, but the thing about water-based lubricants is that it is incredibly difficult to find water-based lubricants that are of high quality in Canada. And by that, I mean, it should have a pH that matches the vaginal pH, which is around 4.5, and an osmolality, which is like how many bits of other things can be mixed into a water-based product. So like Erin always says, like how salty it is. It should be between 380 to 1200 milliosmoles per kilogram. Very sciencey. I can tell you, I don't think I've ever seen any lubricant advertise these numerical values on their bottle. And so how do you find out which ones are the ones that are useful? You either have to go to their website or you have to delve into the scientific research. It's not easy to do. And so, you know, we've got a couple that we recommend that have been tested and that we know kind of stay on track of trying to fall within these. These are actually guidelines set out by the World Health Organization. And so we do kind of track those ones. But when in doubt, silicone doesn't have a pH. You can't mess it up very easily. And if you have pain at all, it's kind of our first recommended course of treatment is to try a silicone-based lubricant. So there you go, hot tip. The other thing we really want you to be monitoring is your vulva, like on the regular, how it looks. Make sure I'm staying on time here. You need a mirror, you need good lighting, you need to move all of the skin around between all the nooks and crannies. So up where the clitoral hood is that we talked about at the beginning of this presentation, you want to open up the space, like the crevice between the outer and inner labia, the two inner labia, and the outer and inner labia. You want to be checking for the same things you'd be looking for in skin cancer in your vulva. So changes in skin color, texture, new bumps or spots, labial and clitoral hood skin changes, so like shape changes, and you should be doing it monthly. Different times a month is great because you'll actually see coloration changes slightly depending on where you are in a menstrual cycle, but certainly after menopause, that can be more regular because we don't see the same hormonal fluctuations. But this has saved lives, I can tell you. I have wished that some of my patients would have done this because we've caught things too late or like into a more severe case of issues. And I don't just mean vulvar cancers, that there's a number of different dermatological things that can present in and around menopause. And we're going to talk about one of those. So lichen sclerosis is a condition that affects about 1 in 1,000 women. However, we think it actually could be 1 in 300 women. Women's health issues get underreported, and so, like, to no one's surprise, we might not actually know the real numbers. The other thing is that lichen sclerosis can also mimic the genital urinary syndrome of menopause. The symptoms can mimic that. They can mimic dermatitises, and they can mimic yeast infections. And so sometimes there are misdiagnoses that happen, and that's why it's so important that if you've sought treatment for a condition and you've used the medication, ointment, whatever that they've given you, and you do not feel better, you must return to the healthcare practitioner and tell them that, because, you know, sometimes differential diagnosis between those conditions can be difficult. And with lichen sclerosis, It's a progressive disease. If you don't treat it, it will continue to get worse. So just so you know the symptoms, vaginal dryness and burning, pain with vaginal penetration, vaginal and vulvar itching, a lightening of the vulvar color. So it's kind of like this whitish coloration, like a paleness comes into the skin. It can look a little bit waxy or shiny, or kind of a bit like scar tissue. It can appear in patches at first, and then as the disease progresses, it can turn into what we call a violin sign. So you'll see the whiteness around the vaginal opening, and then around the anal rectal sphincter, like around the rectum. And at the very later stages of this issue, you can actually have clitoral hood fusion. So the skin can cover the clitoris, and that can decrease clitoral sensation. Sexual stimulation might not be the same. The labia can fuse together, so they'll look almost like they're shrinking, but the labia can actually start to stick together. So that's something definitely we would like to avoid. And I've seen lots of women that thought they've had a yeast infection and have treated themselves over the counter, 2, 3, 4, 5, 6, 8 months in a row, and they haven't gone on to ask for follow-up, and it was actually lichen sclerosis. And so, as I said, the sooner you can catch this, it's an ointment that they use. There's lots of different kind of topical treatments that they use for this, but it's something that should be caught as soon as possible. And that's just, we don't want this to progress if we don't have to have it progress. Okay, a word about constipation. Pelvic floor physiotherapists talk about poop all the time. So constipation needs to be addressed. And I feel like pelvic floor physios care about poop not way more than physicians might, but we're very particular about bowel movements. And the reason for that is we are paying close attention to symptoms throughout the entire pelvic floor. And we know that constipation, aside from being uncomfortable and causing like stomach cramps and just you're not feeling well when you're constipated, it can lead to anal fissures, it can lead to hemorrhoids. We've also seen people certainly that are so constipated that it actually presses, kind of like the pressure comes through the vagina and onto the bladder. So we'll see worsening bladder symptoms because of constipation. We will certainly see worsening prolapse symptoms because of constipation. And I've even had women that experience pain with intercourse because they're so constipated, it takes up vaginal space. Those walls between the vagina and the rectum and the blood, like they're squishy walls. Like they can accommodate babies and large bowel movements. And so they will take up that space if allowed to. And so that's why we ask about it so much. Functional constipation is if you have 2 of the following of these for 3 to 6 months. So you're either straining on more than 25% of your bowel movements, and or lumpy or hard stools more than 25% of the time, the sensation of incomplete evacuation, just fancy talk for like you don't feel done, when you don't feel empty when you finish your bowel movement. You have a sensation of anal rectal obstruction, or you just feel blocked, like you can't get something out. Manual maneuvers, so we discussed that a little bit with the pelvic organ prolapse, but some people feel like they need to apply pressure manually, either from their thumb or their finger around the anus into the vagina in order to defecate completely, and less than 3 poops per week. So the little eyeballs, the little peepers are there. These are values that you should have a pretty good understanding of as well. So if someone were to say to you, like, do you have 2 of these things? You should know if you're constipated. And I feel like not a lot of people do. I think like B is one that's very confusing to people. Some people think if they're pooping daily, then they're not constipated, but if they're straining and they're like little bunny poops, that still counts as constipation. Hot tip is toilet posture. One of the reasons that we really talk about toilet posture is if you sit like this, kind of slouchy on the toilet, then the tubes aren't as lined up as they could be, and it can make for a lot of vaginal pressure when you're trying to have a bowel movement. We also know that if you're perched a little bit too high, because a lot of these toilets are getting really, really tall, which is excellent for your knees and hips, but not so excellent for your pelvic floor. I always make the joke, it's like gonna pay for my children's university. They cause so many problems. it's really taking you out of the squat position. And if you've traveled at all, you know that there are places that really encourage kind of like a squatting toilet position. Therefore comes in the squatty potty or some sort of step stool to give your feet support. You want your knees at least in line with your hips, if not a little bit higher if you do have that hip flexibility, and you don't want a rounded back. You want kind of like a flat back so you're not slouchy and slumped over on the toilet. Those are the things that we're looking for. We also don't want you to hold your breath. When you push, you should at least let some air out. So you shouldn't be red and purple. There's no purple pushing on the toilet. That should be avoided. So give this a try. Sometimes this is all that someone needs, is they just need better positioning on the toilet, which is nice and easy for us. Okay, pelvic floor muscle training. You didn't think you'd get out of here without talking about Kegels and pelvic floor relaxation, did you? I strongly encourage you, if you're going to do pelvic floor muscle exercises, to think about the entire pelvic floor. I spent some time showing you that muscle at the beginning of this talk. So from the pubic bone all the way to the tailbone. You want to think about squeezing and lifting both openings. Sometimes we talk about pretending like there's a jelly bean in the vagina and the anus. Squeeze and lift the beans up to your eyeballs and then put them back down again. You wouldn't do a bicep curl and keep squeezing. You have to put the beans back down. We also find that most people try to inhale or hold their breath when they Kegel, like that, which does not help you at all if you have to cough or sneeze, because coughing and sneezing are exhales, and you need to know how to Kegel while you do those. So we're all going to try this. Well, I'm going to try this, and I can't see any of you, so I'm going to think that you're trying this. You're going to take a big breath in. You're going to blow out and squeeze and lift your beans. You're going to hold the beans for the whole breath out, and when you take your next breath, you put the beans down, and then you repeat. So it's like this lift and lower actioning like a piston, and you'll often hear physios call this piston breathing. So I would give, 5 to 10 of these a row a try. If you're really struggling that you can't feel this lift, or some people really can't feel the lower, that would be an excellent example of when you should be reaching out to a pelvic floor physiotherapist to help you learn those maneuvers. Okay, do we have time? We've got a few minutes. I really want to talk about some other conditions, since I've got your attention, that are strongly associated with menopause: cardiovascular disease and osteoporosis. All right. Cardiovascular disease is the #1 cause of death in women. And one of the problems with cardiovascular disease, I think, is that we think of it as a man's disease. And by and large, men do have cardiovascular issues more than women. However, that's only true until menopause. After menopause, we become in line with men. And so it's important to have an understanding of what cardiovascular disease is, because yes, it's heart attack and stroke, but it's also high blood pressure, heart failure, arrhythmias, which is just like an irregular heart rhythm, blocked or clogged arteries, and peripheral arterial disease, which is a problem with the arteries in the lower body and legs. So you absolutely should know, like I have monitor for symptoms of a heart attack. I hope you don't have to monitor for these symptoms, but you should know what they are, because classically, we think about chest pain and pressure and like left arm, jaw, neck, shoulders maybe, but 42% of women do not experience those types of heart attack symptoms. So they'll get more like lightheadedness or fainting, they'll feel weak, they'll feel it more as pressure in their upper back or pain in their upper abdomen. They'll describe weird feelings, not pain or pressure, weird feelings in the chest, arms, neck, and upper back, severe fatigue. And so sometimes these can mimic menopause, right? Like you can get tired, you can feel fatigue. And women tend to just not be believed the same way when they present to hospital. So you really have to advocate for yourself. If you feel like something is off, it can absolutely be off. And the general public don't know the symptoms of heart attack in women as well as they do for men. And so this is something really to draw your attention to. Fortunately, hot tip is cardiovascular exercise can be really, really great at reducing risk of cardiovascular disease, including heart attack. And so what we're looking for is aerobic activity. So this is kind of your repetitive type exercises that increase your heart rate. Certainly we'll have our patients work in a target heart rate zone, and you can always, Google your target heart rate or go talk to a health professional. But we're generally looking for moderate intensity exercise, about 150 minutes per week on the low end, all the way up to 300 minutes per week. And so that looks like you know, like if you were exercising, you could get a sentence out and then you would have to take a breath. Like it's that kind of intensity. That's what we're looking for when we're talking about moderate intensity exercise. You can do vigorous intensity exercise as well, which would be where it's much more difficult to take a breath. Maybe you're only getting a word out in between. For moderate intensity exercise, that might be like 20 minutes, 7 days a week, 30 minutes, 5 days a week. For vigorous intensity, it might be 10 minutes a day, 15 minutes a day. Some people like to do a combination of both. It really comes down to personal preference. I do not love vigorous intensity exercise. I prefer moderate intensity exercise. Or if you are already at a moderately high to high risk of a cardiovascular event, your physician might recommend you don't do vigorous intensity exercise until getting a stress test. And so if you are brand new to exercise and you have concerns at all, it's really a good idea to fill out a PAR Med X. You can Google them. It's like a questionnaire, and then you can go through your responses with your doctor if you think that you are at high risk of some sort of cardiovascular disease. Okay, osteoporosis. So osteoporosis is low bone density that can increase your risk of having a fragility fracture. And a fragility fracture is a low trauma broken bone. So things like falling from a standing position, that shouldn't break a bone. You know, if you fell down the stairs, that makes sense. That's not a low trauma fracture. But falling from a standing position, you know, walking around the corner and hitting your arm against the door frame and that causing a fracture, those are fragility fractures, and they're more commonly seen in the wrist, the upper arm, the spine, the pelvis, and the hips. I think we hear a lot about hip fractures, and so hip fractures, if someone's had a hip fracture, like a fragility fracture in their hip, they have an increased risk of death by 8 to 36% in the following year. And so we take osteoporosis and we take fragility fractures very, very seriously. Many Canadians are poorly screened for osteoporosis. Less than half of Canadians who should be screened are screened. And of the ones who are screened, who are then offered either pharmaceutical treatment or exercise treatment, only about 40% of them actually follow their recommended treatment plan. And so it's something that we want on your, top of mind for sure when we talk about healthy aging. Women are 4 times more likely to have osteoporosis than men. We suspect that is because of estrogen levels. So just like estrogen is cardioprotective, we think, we know estrogen is involved in bone formation. And so the transition to and within the first 3 years of menopause can result in about a 10% bone mineral density loss. And after menopause, your rate at which you lose bone mass will increase as well to about 0.5 to 1% per year. So for those who go into early menopause, which is menopause before the age of 45, it's associated with an even more increased risk for fractures. And that's simply because if you go into early menopause and you have less estrogen for longer periods of time, there's more of a strain on the bone formation and bone maintenance during that time frame. And so, surprise, surprise, one of the best things that you can do for osteoporosis, for prevention and for management, is exercise. We know that strength training is really important, and it can't just be dinky 1-pound weights. You need some serious strength training. Postural exercises to keep you out of that like forward head, kind of curved spine position. You want impact training, so jumping, running. If that doesn't sound good for your knees or hips, then even bouncing or doing more stairs like step ups and whatnot. And then balance training. To get a fragility fracture, sometimes you need to fall. So if you have good balance and you reduce your risk of falls, that can reduce your risk of fragility fractures. So we strongly encourage things like your classic balance exercises, but also yoga, dance classes, that sort of thing. So really menopause, we are hoping is that we're kind of shifting the perspective on menopause, and this is really the time to focus on you, to evaluate your current health status, checking with your primary care practitioner, book your appointments with your relevant Health Pro team. As I said, there's lots of practitioners out there that are happy to help you with their expertise around all things menopause, but to make sure that you're actually addressing this at an appropriate time before symptoms get to be too bad. And if you're already experiencing symptoms, there's lots and lots and lots that can be done. I do also want to draw your attention to, because we're quite proud of this, Reconnect Plus, which is our online streaming program that was launched in October, I think. And in particular, there's a 12-week menopause program. I'm going to show you some of it. It's all done out week by week. So not only is it your exercise all done for you, so you get your videos of, your balance exercises you should be doing, your types of like resistance training you should be doing. We talk about cardiovascular exercise and how to find your target heart rate. We talk about range of motion and flexibility, but each week you also get education videos. So similar to tonight, well, they're not as long as tonight, most of them, like little bits of education so that you learn a bit more about menopause and things to monitor for as each week goes on. So as I said, you can kind of see what some of the topics are here, but we've really diligently planned this out. There's lots of experts that are involved. So we've got interviews with dietitians. We have, you know, the gynecologist that we work with, Dr. Karen DeRosier, gives 2 talks. Aaron is our other pelvic floor physiotherapist. Aaron, my co-owner, gives a fabulous talk about like pessaries and what they're good for. And so it's just lots and lots of information. You get 1 week for free trial. So everyone can have a week free. It's $17 a month. You can cancel it anytime. If you just want to do 3 months of menopause program and then cancel it, you are not penalized for that. And if you're interested at all, we do have a promo code for 50% off the first month. It's early bird, all caps. You would just enter that in checkout as you go through. But you can always just go to the website and check it out. You're welcome to kind of peruse our practitioners at our clinic. But most of all, thank you so much for stopping in tonight. I know that people's time is very valuable, and I really appreciate the support that we get from our community. And I hope very much that that offered you guys some education and information and answered some of the questions that you might have about menopause, leading up to menopause, and such. So just want to make sure that I have stopped sharing here. Stop screen share. Can you guys see my face again? I don't know. I think we'll end the recording. And if anyone has any questions, I'll stick around for a few minutes if you want to ask them. Okay, so I'll press stop the recording.